Today, I'm presenting a case of 47-year-old male presented to ER with alleged history of fall from top of a truck along with wooden logs. On initial 10-second assessment, patient is alert, can talk, was kept on spine board. Primary survey, airway patent, no secretions. Patient can talk and complete one sentence. Cervical spine, patient was kept on spine board and Philadelphia collar was applied. No external penetrating injuries, no signs of blunt trauma to neck, no dilated neck veins.
Okay.
Breathing, respiratory rate 18 per minute, saturation 98% in room air, chest movements are normal, bilateral air entry equal, no added sounds. Circulation, heart rate is 82 per minute, BP 110/70 millimeters of mercury.
Okay.
All peripheral pulses equally felt. At this time, 2 large IV bore cannula were secured.
Okay.
No active bleeding sites. Disability, GCS was 15/15, pupils bilaterally equal and reacting to light. Exposure temperature normal, GRBS is 105 milligram per deciliter.
Okay.
Adjuncts to primary survey, we had taken an ABG, showed no acid-based imbalance or electrolyte imbalances. Lactates was normal. We had ordered for a chest X-ray AP, pelvis X-ray AP, and X-ray C-spine, AP lateral, and whole spine screening.
Okay. Can you come back to the mechanism of injury again?
Alleged history of fall from top of truck along with the wooden logs.
Top of a truck, he has fallen down.
He was standing on.
And the wooden truck, the wooden blocks fell over him.
No, sides.
It didn't fall over him. So he just have a fall from a height. That's it, no? Fall from a height. How was it? He fell down, hitting the face or hitting back?
Hitting back.
Hitting back, okay. So whether the force was, what was the impact? Whether it was total impact or he was just over the pelvis there was an impact, over the calcaneum there was an impact? So
no, on the pelvis.
Over the pelvis there was an impact, okay. So there was nothing that came and fall over him, okay. So basically fall from height but he fall down on his pelvis, okay.
Yes.
That's the history, okay. So then when he came into the ER, A, B was fine. And circulation also, blood pressure was maintaining.
Yes.
What was the blood pressure?
110/70.
110/70. Heart rate?
Heart rate is 82.
82 per minute. Okay. Heart rate 82 per minute, 110/70. Capillary refilling time normal. Then among D, disability?
GCS is full.
GCS is full.
Pupils bilaterally equal reacting to light.
Equal and reacting to light. And exposure?
Temperature is normal and GRBS 105 milligram per deciliter.
Okay. Any abrasions, bruises, visible bruises, externally, anything you are able to see?
Right side shoulder on the back was only.
Okay. Only there is a right side shoulder abrasion. And did you do a log roll? Did you do a log roll is my question. Whether you will do a log roll or we will not do a log roll. Have you done a log roll?
We haven't done.
We haven't done. So suppose you should do or should not do?
You should do.
Okay. So you should do a log roll. That is what you're coming. Like, we will come back to that later. Okay. So we have a patient, but A, B, C, D, everything is fine. Pain?
He was complaining pain over the buttocks and the anterior aspect of the pelvis.
Okay. Anterior aspect. So what was done for the pain?
Paracetamol, injection paracetamol, 1 gram IV stat was given.
Okay. So from your history, he just fallen on his buttocks. That is the history that you have got. And he has got significant pain over the buttocks or the perineal region he is having pain. So you have done your primary assessment. You didn't find anything in the primary assessment. And you went ahead with the adjuncts to the primary survey. ABG was okay. ABG was okay. ECG was fine. X-rays, what all X-rays you have taken? You have to take 2 X-rays. Chest X-rays and pelvis X-ray. Pelvis X-ray.
Pelvis X-ray was showing more than up to 3 centimeters of widening of the pubic symphysis.
Up to 2 centimeter, 3 centimeter widening of the pubic symphysis. Okay. So anything else that you could see in that X-ray? No.
No, pelvis X-ray.
Fine. Then coming to the fast focus assessment sonography.
EFAST was negative.
EFAST was negative. Okay. FAST was negative. Then X-ray was showing an widened pubic symphysis. That's the only thing that you are able to see. Okay, widened pubic symphysis. And coming to the secondary assessment, sample history.
47-year-old male, known case of hypertension, was brought to ER with alleged history of falling from top of truck along with wooden logs, sustaining injury to his lower back. He developed pain over the buttocks and on anterior aspect of the pelvis. He was not able to bear weight and mobilize. He also complains of pain over the lower back. No history of LOC or head injury, vomiting, seizures or ENT blood.
Okay.
Head and
Head to toe examination.
head and maxillofacial.
Anything positive. I want only positive findings. I want to know any deformity, contusion, aberration,
Yeah.
penetration, tenderness, laceration,
Therefore,
or swelling of any of the region.
for
You
the
said regarding an aberration. Coming to the pelvic examination, I want to know what was happening to the pendulous anterior superior iliac spine. That region, you could see any hematoma or you could see any superficial aberrations, whether there was any scrotal hematoma, whether there was any bleeding from the meatus, bleeding PR. This is what I wanted to know.
pelvic compression test was positive. No other.
Pelvic compression test you did for this patient. That is the, you should not do. See, that is one of the major errors that we all practice, and the springing and rocking, rolling of the pelvis should not be done when you suspect a pelvic fracture. That you should not do. So, why you should not do?
More displacement may happen.
See, what is the problem in pelvic injuries? What is the killer in a pelvic injury?
Bleeding, neurovascular injuries, vascular
Not neurovascular. You can specifically say it is the vascular injuries. It is the killer. Okay. So you can get like 2 liters of blood that is being involved or getting collected inside a pelvis. So right now he is hemodynamically stable, and you are doing a pelvic compression test, and what will happen? The clot will get dislodged. Whatever be the clot, that hemorrhage has stopped, that you are doing these things and you are dislodging the clot, and he is going for a coagulopathy. So that should not be done. So make sure that is the question that I asked in between, log rolling. When you suspect a unstable pelvic fracture, unless and until you are very sure it's a stable pelvic fracture, unless and until you are not very sure, don't go ahead with a log rolling also. So these are the two key things that in the initial assessment that you need to consider. So whenever you suspect an unstable pelvic fracture, specifically you are suspecting only a pelvic injury initially, and maybe a spinal injury also from whatever be the mechanism that has been attributed. That is why we have to always say, I used to say mechanism of injury in trauma is very, very important. So brief mechanism of injury is very important. Depending upon that, we can think what are the possible injuries that you will suspect. From the list that mechanism of injury we can come down, like first will be my pelvic injury. The next will be spinal cord injury. Definitely, I'm not saying that he can't have a blunt abdominal trauma or anything, but this will be our priority. Maybe a long bone fracture also can be there, but this will be our priority. So, most importantly, you should not be doing a pelvic compression test for this PCT and all. This rocking and springing and just rotating and see whether the pelvis is stable and unstable should not be done. So that is first. What is the reason I told you? Clot dislodgement. What type of bleeding they will have? This sort of pelvic injury patients will have. My question is whether it's a venous bleed or an arterial hemorrhage. Most commonly it is venous plexus. It is the sacral venous plexus. They will bleed and the patient will die. So that is the most important thing. So sacral venous plexus bleed is the deadliest thing that can happen for a pelvic injury patient. Okay. So a patient coming with suspected pelvic injury, our idea is to see whether the pelvis is stable or unstable. What are the type of fractures that he has? What else he have other injury, whether we can have an arterial injury, but most common is pelvic injury. We can have iliac artery injuries and all you can have, but most commonly this is pelvic, the sacral venous plexus is that what is getting involved. So our concern will be to see whether he is stable or unstable. In the sense, the pelvis I am saying, I am not saying regarding the hemodynamic status. I am saying the stability of the pelvis. Open, so as you say, how you should know what are the different types of classification of pelvic injuries.
Pelvic fractures is divided according to Young-Burgess classification based on mechanism of injury and direction of force.
Okay.
There are 3 types: lateral compression, which is the most common type, then anterior-posterior compression, which is open book, and then the vertical shear. Lateral compression,
lateral compression, as the name says, there is a force that is coming externally, and it is coming from the lateral side, and there can be lateral fractures. So what are the bones that is involved in the pelvic structure? Can you tell? You have posteriorly or anteriorly, you can call it a sacrum, then
pubic rami.
Pubic rami, then
Pubic symphysis.
Pubic symphysis and the ischium. So ischium, ilium, these are the three bones that all together forms the pelvic structure. So we have any of this, you can have lateral compression, you can have vertical shear. Vertical shear is something like falling from a height, or when you are going and hitting there and the patient is tilting or being thrown out of the car and all, they can have vertical shear sort of a fracture. Then it's the open book fracture, and it can be a complicated one also. It can be a combination of open book, it can be a combination of open shear, it can be a combination of lateral compression also. So that is too much complicated pelvic fractures. So this classification, what is this classification called as?
Young-Burgers.
Young-Burgers classification. And when you see Young-Burgers classification, type 2 and above is complicated, and these are unstable fractures. Okay, so these unstable fractures, you need to stabilize them immediately. So stable fractures, okay, you have time, but these are all unstable fractures. So usually an open book fracture is reasonably a stable one. So the next question arises is, what is the next immediate thing that you need to do when you suspect a pelvic injury in the ED?
Stabilize the
pelvis. How will you stabilize the pelvis?
With pelvic binder.
You can get ideally a commercially available pelvic binder. If you are not getting a commercially available pelvic binder, you need to use the bed sheet. So how will you wrap it?
Place the bed sheet below the pelvis, and then place stand 2 persons on the either side.
Okay.
And always.
What should be the level? That is important. What is the upper level? It should be at the level of anterior superior iliac spine. So that is very important. Anterior superior iliac spine, that should be the level, and you should be tying it in such a way that nobody is coming and removing it. That is very important. If there is another, you cannot call and suppose what will happen in common in ED, you have done a pelvic binder, you have stabilized the patient and he is hemodynamically stable. You are calling for your orthopedic colleagues or someone you are calling them, they wanted to examine, they will come and just open it. You have to be very, very strict instruction. When you are applying this pelvic binder, you should not be allowing them to remove it unless and until the pelvis is stabilized, maybe by putting an external fix, or unless until you have done a CT and you are making sure that there is no extravasation or there is no other hemorrhage. You have to make sure that till that time that pelvic binder should be in place. The pelvic binder should not be removed like this. So that is one of the commonest mistakes that will happen. So that's what I am saying. Once you apply a pelvic binder, make sure that that pelvic binder is retained. And once the pelvis is putting by an external fixator or you are controlling the hemorrhage, then only you should be removing a pelvic binder. So removing a pelvic binder is a next important thing. And applying a pelvic binder also, it's important. When you have an open book fracture, you wanted to apply a pelvic binder. That is the next question. Yes, you can apply a pelvic binder. But the problem is that when you have a vertical shear and this complicated fracture, at that time, pelvic binder will not help. And it is you ideally should be avoided in this situation. But when you have a injury like this, you can definitely go ahead and apply your pelvic binder. So that is the next question. So now how will you are seeing the X-ray? Okay. So how will you assess a pelvic injury in an X-ray? Pelvic fracture in an X-ray. X-ray pelvis. APV you have taken.
Look for the pubic symphysis.
So most importantly, what you need to do, we need to remember 3 rings. One is a total pelvic ring and obturator foramina, both the obturator foramina. Whether you have to look for any interruptions in this foramina, any interruption in this circles, these rings you need to see. If there is any interruptions in this ring, you need to consider that there is a fracture. So interruption of the ring is one thing. And as you said, the distance of the pubic rami. What is the accepted? I think it is less than 5 mm or something. I don't remember exactly. 2 to 3. 2.5 centimeter. We have to just recheck it, because if it is widened, that is again very important. Then sacroiliac joint, the separation, the spaces and the rings. So that is the most important thing that you need to look in for an X-ray. So these 3 rings, the simple thing you can just go through and you can just run through your finger and you just see whether there is any interruption in the ring, because sometimes we can miss and there can be a fracture which is overlying and we can miss that. So you can just run through this pelvic ring and through the obturator foramina. If there is any disruption, any interruption in the line, you need to think in terms of a pelvic fracture, and definitely that patient might need a CT for further confirmation. Okay, so what are the, as I told, the major challenge in a pelvic trauma is the circulation problems. The problem, how a pelvic, I'm not asking anatomy, I'll leave it that to fine. How you start resuscitating a patient with pelvic injury? How will you manage your hemorrhage control? So one is pelvic binder, then next one?
Fluid boluses can be tried.
Okay.
And if it is, patient is responding,
Patient is responding, then depending upon three, we know transient responders, rapid responder, non-responders. Sometimes the patient can respond, sometimes the patient will not respond. But the most important thing that you need to keep in mind is that they will definitely go for an hemorrhagic shock. So if the patient has got an unstable pelvic fracture, you need to definitely think in terms of an intervention. So maybe an exploration immediately, or maybe an external fixation, or else you need to go to think of something like a Ribova. What is Ribova standing for?
Resuscitative endovascular balloon occlusion of aorta.
Aorta. That is one of the rarest of the situation. You need to do ahead with an procedure called as REBOA. That is one thing that has been found to be effective in patients with pelvic injury. See, pelvic injury, the problem is that the amount of shear force, it's very huge. So normally a fall will not cause the damage. But a pelvic injury, when to happen, that amount of force that has happened in that injury is very huge. So you need to think that deeper structures are getting involved. So if you have a patient with acetabulum fracture, are you happy? Acetabulum fracture?
No.
Why?
It may progress to...
So when you see about acetabulum fracture, you need to remember the acetabulum is formed by the three bones. The three bones are affected here. So it is again causing an unstable fracture only. So acetabulum fracture and isolated acetabulum fracture itself shows that the mechanism of injury and the force that is involved is too much. So an acetabulum fracture is very, very dangerous one also. So acetabulum fracture, this open book, vertical shear, lateral compression, and your combination of all those things are the common fractures that you need to remember in different type of pelvic injury. So the resuscitation standard is the same. You are go ahead with the A, B, C. You need to look for the other injuries all, and blood transfusion, massive transfusion protocol, all holds good here also. And giving your tranexaminic acid, 1 gram you can give stat, and 1 gram every 8th hourly till the hemorrhage is getting resolved. And most important question is whether you will go ahead and catheterize this patient or not.
No, if there is meatal bleeding, we should suspect a urethral injury.
So okay.
We should do a suprapubic cystostomy.
Suprapubic cystostomy, yes. Suppose there is no meatal injury. There is no meatal injury, then this is the bigger challenge here, because I have told you before itself, because when you are catheterizing, a tamponade effect, the bladder is creating a tamponade effect. Suppose there is 1.5 liter of urine which is inside the bladder, and it is causing a tamponade effect to the plexus. So once you are suddenly releasing that, the tamponade effect might go, and you need to think of a sudden deterioration. So that is one thing that you have to be very careful when you are having a patient in ED. Routinely we just go ahead and catheterize this group of patients, but pelvic injury, when you have in them, whether to catheterize or not, that itself is a question. When you suspect an urethral injury, yes, you have to be very cautious. When you see blood in the meatus, you will keep that in mind, and you go ahead with the suprapubic cystostomy. But again, the tamponade effect should not be suddenly released. If you are removing the tamponade effect suddenly, the patient can deteriorate rapidly, and the patient can die on the ER itself. So the mortality rate is very high with the pelvic injury. It's approximately around 80% of the unstable fractures. 80 to 90% mortality rate is there for a pelvic fracture, and definitely there will be other associated injuries also. So you have to be very, very careful. So when you will suspect a pelvic injury, as you told, blood in the meatus, scrotal hematoma, then where else bleeding PR. So these are the things we will suspect. Or we are seeing a rollover. There is a rollover mark. The tire have run over. That is very important. When the patient is lying down, the patient can roll over that, and the tire marks are seeing over the pelvis. So very, very bad injuries. So they can have all type of pelvic fractures. Also the deeper structures might also be involved. Not just the plexus. The other deeper structures will also be involved, including your urinary bladder. There can be injuries. So these are the very crucial things that you need to look into. And once the pelvis is fixed, then only you should be removing your pelvic binder. So there are a lot of treatment options. You need to put an external fixator, and you need to stabilize the pelvis. What are the other options that you have? Open book fracture like this, you need anything to be done? Open book, what was done for this patient?
Patient was done, open reduction was done there was a dislocation of sacroiliac joint also. So cancer screw fixation was also done. So he had a complex. It was not just an open book fracture. There was an associated dislocation. Fracture was there? Any fractures was there? Except for the widening of the pubic symphysis? No, sir. There was right hip acetabular fracture was present. Right transverse process fracture of L2 to L4 and displaced fracture of left L5 transverse process.
So from the mechanism injury, whatever we have suspected, he had all those things. So a stubulum fracture, yes, again it's a very unstable fracture. Luckily, he hasn't gone into the hemorrhagic complications because of the venous plexus was spared, and we were suspecting in lumbar fractures. He has lumbar spine fracture. So these were the fractures that we were suspecting from the mechanism of injury. So that is why I said always you go ahead with the mechanism of injury. You have a thorough mechanism of injury. You can diagnose what are the possible complications, what are the possible fractures that this patient is going to have. Whether it's a simple open book fracture, you basically doesn't need any treatment at all. If just there is a widening, it may be a bed rest and might be all that is required for that patient. Maybe unstable, definitely yes. You need to fix all those things. It's very, very, very crucial. And one more important thing is that this is the area where you need to use your coagulopathy as one of the major killer, because you are giving a lot of fluids. In trauma, as I told, blunt abdominal trauma, chest trauma and pelvic injuries, long bone fractures, we will be resuscitating them with a lot of fluid. So that is a time that you need to think about your hypotensive resuscitation and your damage control surgery. We are not planning here. If the patient comes to us with an hemorrhage and all, we are not planning to fix the spine and all. We are just planning, our aim is to stabilize him right now, and we need to stop the bleeding. Maybe a pelvic binder, we are putting a pelvic binder, and pelvic external fixator we are putting, and we are just stabilizing the pelvis, and later on only we will be doing the further procedure. And most important, massive transfusion protocol also, and the role of TEG, thromboelastography. So as a postgraduate, you should know how to use TEG in a trauma patient, specifically in pelvic injury. So you should be giving blood products according to thromboelastography, TEG. So that is one area that has been a lot of research that has been happening in the last 10 years regarding trauma. So when we say massive transfusion, we used to mean that more than, what is massive transfusion protocol? MTP? More than 6 units of blood is being required to be transfused to the patient within the next 1 or 2 hours, or you are definitely sure that the patient needs the whole blood to be transfused. Suppose 5 liters of blood you need to be transfused in the next 24 hours, you can activate the massive transfusion protocol. When you activate the massive transfusion protocol, our role is 1:1:1. 1:1:1 means 1 PRBC, 1 FFP and 1 platelet you need to give. If you are not able to do that, at least you do it with 2:1:1. So coagulopathy is very, that is the killer. What are the killers in trauma? 3 things: acidosis, coagulopathy and hypothermia. So these are the 3 killers that you need to remember. The triad of death can be happening in trauma because of this. So pelvic injury is very notorious to produce any of these things. You will give a lot of fluid, so you'll go to dilation, coagulopathy. You need to do blood transfusion, again coagulopathy. You are transfusing fluid, hypothermia. You are giving chloride, acidosis, a lot of normal saline, so hyperchloremic acidosis. So these are the reasons why they develop all those things. So you need to keep those things. So pelvic injury in a nutshell, what you need to remember is that pelvic injury is not simple. Pelvic injury, I don't want a pelvic injury patient to come in my shift, because that's one of the worst injuries that the patient can have following a trauma. Even if a blunt abdominal trauma, I'm okay with it, but pelvic injury is too much complicated, because we cannot do an external hemorrhage control or any of this thing. Only thing what we can do a pelvic binder, and if it is an arterial bleed, the surgeon can just go in and just can clamp it and the arterial bleed can be stopped. But here it's a venous plexus bleed. So that the bleed, it will not be like a hemorrhage, it will be oozing and there will be a lot of blood loss. So pelvic injury is one of the worst things that you can have, and it's the mortality rate is very high. And when you will suspect a pelvic injury, definitely with the mechanism of injury, with that in background, or any of these suspects. Suppose a blunt abdominal trauma is there, on top of that there is a possible scrotal hematoma, always suspect a pelvic injury. And what all things you should do, you should not do. Very clear. Pelvic compression test, avoid a pelvic compression test when you suspect a pelvic injury. Next thing, log rolling. If unless and until you are making sure that the pelvis is stable, you don't log roll. Again, the concept is the same. While you are log rolling, the clot can get dislodged and the patient can bleed again. So log rolling, and these are the 2 things basically that we all do wrong in case of a pelvic injury. But just keep those things in your mind. And classification we have gone through, and how will you evaluate an X-ray, and if you have any doubt in mind, go ahead with the CT. CT is the next gold standard for the evaluation. HRCT or MDCT pelvis you can get, so you will be able to reconstruct the images and see where exactly is the fracture. Certain fractures can be missed, but if you suspect, X-rays is fine. still you can go ahead with an MDCT pelvis and see for the fractures. Okay, anything you wanted to add on? Okay, fine. Thank you.
Thank you.